or human public health or any other activity, and it's to strengthen surveillance. This is a background that we talked this morning and tell all the activities. So this, and this is the common problem is that the One Health usually focuses, which is the zoonotic diseases and antimicrobial resistance, which affects all human, and that touches the all the drugs that we are using, the bugs that we are training are just like humans, just like other humans. When we go out to the in front of the gate, if that gate is blocked and there is a threat, we will find some other way, whether we will use it, ladders or something like that. The bugs has also that kind of ability, although they are not saying. What they will do, they will develop certain resistance. They will mutate, they will camouflage, and all of those. And many of the patients, particularly those who doesn't have laboratory capacities that can test the resistance of those strains and say, okay, well, it's a strain mutation that become resistant to drugs, common drugs that we are using. So it says then in that situation, most of the physician is treating those patients. If it's a septic condition or some others, they will consider, okay, it's a resistant. Sometimes it may not be a resistant because of the drug importation, which we don't know the qualities. If we do a random survey and take all the drugs one by one from different pharmacies, and then take it to the chemical laboratories that are capable of telling us, for example, how many, whether it's the right dose, whether it's the capable to treat those diseases. Then something that we consider clinically resistant may not be resistant, but due to bad drugs that we were using. So those kind of challenges are everywhere. So those require surveillance as well. For example, the food safety and food security is about because when there is no food, there is no, what should be animals and humans cannot survive, and food security is the same. And then vector-borne diseases that are becoming resistant, that are transmitting from animal to humans or human to animals sometimes. Environmental contamination and other health threats shared by people, animals, and the environment. Even the fields of chronic diseases, for example, TB, I think, no, for example, one of the chronic diseases was even malaria is also, there is a vector, but it's not it's acute most of the time. The occupational health is also another area. For example, the Congo Crimea virus, there was a case that we export the sheep to Arabia, to Gulf. And there was a case that in UAE that sheep came from Somalia were tested positive. But the way it was learned, there was doctors treating people, and then people, they come to the hemorrhagic, and then they all die. And there was one common thing that they were all abattoirs, slaughterhouses, something like that. Then they were tracing what they were exposed to, and they found that it was Congo Crimea. And that's why one time I remember it was stopped in our animals. Also, One Health is an effective way to fight health issues at the human-animal environment interface, including zoonotic disease. So CDC uses One Health approach by involving experts, who is involved. You have to know what competence, who needs the competence, what humans involved in animal health, human health, and something like that. There is the animal. These are experts in animal, human, environmental health, and other relevant disciplines and sectors in monitoring and controlling public health threats to learn about how disease spread among animals, plants, and environment, which requires an epidemiological competence. So what activities One Health does? What does it do? Successful public health interventions require the cooperation of these human, animal, and environmental health partners. Cooperation. And I remember Dr. Muhammad Ibrahim was from Jigjiga University. This is something common, the 3 C's: collaboration, communication, and coordination. There is nothing much important in those 3 C's to be successful, the One Health programs. You have to know from your heart that you have to communicate. If you see an animal health problem, something like that, go and talk to the, for example, inform the human health, the Department of Public Health, then they will come and at the same time investigate whether there is human exposure at the same time and then understand that. So that cooperation. And professionals in human health, including doctors, nurses, public health practitioners, epidemiologists, animal health, environmental ecologists, wildlife experts, and other areas of expertise also, this communication. You have to be communication specialists. You have to know how to coordinate certain activities, who to talk, who is the focal point, which department, which the person. So you have to know exactly what are the contacts and all of those so that you can communicate well and coordinate activities. Other relevant players include law enforcement, because there is the cross-border. You need the law enforcement also people to collaborate with the public health. When they are crossing, for example, Wachal area, there should be some, and it was very difficult actually in opening cross-border boundaries, the problems they face. When we put some surveillance officers over there, people, they just move somewhere else and get it from somewhere else. So they know how to bypass. So, but we have to also, law enforcement is also included. Policy makers, they have to be aware they are the ones who can drive the policies and tell them, okay, this is the policy of the nation and we have to fulfill it. The programs has to be based on that. The implementation has to be based. With humans, they have to map all who is involved and something like that. So the policy approve is all of those involvements. You have to know. Agriculture, same thing. Communities and even pet owners. And no one person, organization or sector can address issues in the animal-human environment interface alone. What are human health? What are the animal health? What's agriculture? Nobody can succeed. These kind of verticalities that we are in, and at the same time, the in cooperation, the non-collaboration, and in transition territorial mentality of implementing our programs, and that's the ownership. Ownership has to be, it's a nation, we own, all of us we own, not one person, not one department, not one unit or one ministry. So this is for the humans, for example, who are working and protecting both human and animal and environmental health and other partners, has to have a good coordination, good communication and collaboration so that we will protect the health of the environment, humans and animals. Okay, these are common diseases, for example, that we are known, the rabies, the bovine TB, brucellosis, echinococcosis. So it requires infectious disease specialists, tropical disease specialists that actually interested in the diagnosis of those diseases and in the biology of all of those diseases. So, and also the epidemiology, and they have to know how to investigate when certain disease emerge as an outbreak. Okay, then capacity building for health. Okay, human resources involved in actually prevention, detection and response. We have to have these capacities to prevent, to detect the disease, and to respond so that we can control the disease to spread to others. So in this area, for example, the field epidemiology training program, which I was telling you, actually incapacitates the humans who are involved in animal health as well as human health. So prevention, they have to know how to prevent. What kind of arsenal in prevention you have it, but you have also the detection capacity. What will be involved in the detection capacity? There is the laboratory, there is the clinicians, there is the epidemiologists who analyze all of those data, and all of those that are capable, and then the human resource and who to collaborate. The list of outbreak investigation, there are 9 steps you have to follow. And at the same time, then now you have to respond. How to respond? Control. Is it only vaccination? Is it requires vaccination? Or is it human awareness? Or should we cross borders? And we have to follow what they call the IHR rules, international health regulations, so that we can satisfy all of those without hindering the goods or even the economy of the countries unnecessarily. So you have to know the extent, the scope of all of those. The one thing I will emphasize more, the field epidemiology training program. I know Kenya has it, and I know the Kenya program is field laboratory training epidemiology program. What the CDC encourages, these programs are based in the ministries of health. CDC discourages those to be university, academia level, so that you will not train. So they will not. For example, but what we have found when I was managing the program in Yemen, and even training the one is in Bangladesh, and also in Egypt, in Jordan, what we have found that what
In addition to that, the disease has export importance, whereby if bovine tuberculosis is endemic in your country, you might have restrictions on exporting live animals. Despite of the importance of bovine tuberculosis, it is still a neglected disease, and because of that, Amud and IGAT Sheikh Technical Fraternity collaborated to undertake this research so that we know the status of the disease in the region. The study contains two. One was sampling the cattle and testing it serologically so that we know the animals that are positive. We also done an interview whereby the cattle owners or people who are animal herders are interviewed to know the risk factors that might contribute to the occurrence of the disease. This is me doing the ELISA test. This is the result. And we have tested 360 cattle, and we found out 31 of that animals were positive. What we did was, we have chosen 18 households from each village. That 18 households, we are testing only one animal from a family. And because the disease can be transmitted through airborne, and we can see that the other animals that we are living with that animal, they might have the disease, which can actually increase the prevalence of bovine tuberculosis. The risk factors were people all of them were having close proximity with the animals, and actually they were living with the animals. In addition to that, the consumption of unpasteurized or unboiled milk were very common in the study area. In conclusion, this was the prevalence that was recorded using bovigam test analysis. Some of the risk factors were having close proximity with cattle and also using unpasteurized dairy products. And to just know the status of human TB, we have asked from Hargeisa TB Center to provide us some data. This is what they gave us. In only 1 year, we have like 480 cases of extrapulmonary TB and 643 cases of pulmonary TB. Bovine tuberculosis is, for example, Mycobacterium bovis, which is the leading cause of bovine tuberculosis, it is mainly pulmonary, not extrapulmonary. And in total, this is like in 1 year, from Hargeisa TB Center alone, we have 1,123 cases. And if we divide that in the 12 months, in each month, 94 cases of TB we are diagnosed in Hargeisa TB Center alone. I don't know if this is alarming, because we know that there are also cases that might be under-diagnosed, and also there are people who visit the private sector for diagnosis, and also there are people who travel to the neighboring countries or far areas to get tested. The mother? I don't know. One slide remaining, no problem. So the proposed recommendations are that there should be an awareness creation campaigns to the livestock owners and to the public as a whole, because people who consume the milk, they are the public, and they believe that if they boil the milk will lose some of its nutrients. So there should be an awareness creation campaigns. Awareness creation campaigns. Also, there should be other researches should also be conducted so that the status of bovine tuberculosis is known in other regions of Somaliland, because this was only in our region. Also, researches will be conducted so that the status of TB is documented in other species, because even the camel can acquire TB. And in conclusion, this study was conducted by Amud University, and Master Dr. Jibril, Dr. Abdiqadir from Amud University, we are the three researchers that contributed to this research. The research was funded by HORN project, and that's all. Thank you for your attention.
Another dose of clap, please. Because in terms of gender, I think that's the only lady who has presented today. She deserves another one, please. Thank you very much. Thank you. Now allow me to invite Dr. Farah Isi, who is going to present on evaluation of surveillance systems, risk mapping, assessment of CAPs among risk high groups in the Horn of Africa. Thank you. Okay. Meanwhile, Dr. Dismas Ongore, check your boarding pass. Not that one. Thank you. If you like drinking untreated milk, be careful, and also beer. Is it beer? Liver. Yeah, so bear. Yeah, you have to be careful. Otherwise, bovine tuberculosis is on the way. Thank you. Welcome, sir.
Thank you very much. Thank you very much, Mr. Chairman. I am back. I am Farah again, and I will be sharing with you another One Health related project funded by HORN, and this was one of the earlier projects funded by HORN through Redis University, and that's where I was working before I have started my recent studies. So this one and another research related to COVID-19 were the researches that I was co-investigating while I was in Red's University. This is the title of the project. It was quite an ambitious project that is covering the whole of Horn of Africa. That means we were targeting 5 countries and more than 12 districts. So this is the title: Evaluation of Surveillance Systems, Risk Mapping, and Assessment of Knowledge, Attitude, and Practice among high-risk groups in the Horn of Africa. So anthrax is a zoonotic disease. That means a disease that can be transmitted from animals to human, and it is caused by a bacterium called Bacillus anthracis, and it's one of the most well-known zoonotic diseases. And it's primarily a disease of animals, particularly animals that we call herbivores. That means animals that graze. But the outbreaks on human can happen potentially with bad consequences. And in human, it is classified into 3 forms. We have cutaneous form, that means the skin. We also have gastrointestinal form of anthrax. We also have inhalational form of anthrax. So in the available literature in the Horn is scarce. The disease is very common in Kenya and Ethiopia, but particularly there were recent outbreaks in different districts in Kenya. We had outbreaks in Nakuru County, Kiambu County, Murang'a County, and the latest outbreaks were 2019 in Meru County. And then AU-IPAR also reported that the disease is also common and reported from Somalia. Maybe 44 cases were reported. And after Ethiopia, it was the second one at that time. And then the disease has a common vernacular name. That means the local name. It is called in Somali Kut. Kut means anthrax, and that is showing that the disease again is prevalent in the Somali ecosystem. In Eritrea again, we have, there's no clear data coming from Eritrea. Eritrea is one of the countries we are targeting. So we don't have much information from Eritrea, but it's also common in Ethiopia, and this is the number of human cases, 5,000 and 26,000 plus cases of animals in 2013 only. So these are the objectives of our project. Among them is to assess and evaluate the current existing surveillance system in the Horn of Africa, particularly if there is an integration, if there is one health kind of surveillance system, if maybe human health and animal health departments are integrating or collaborating when they are reporting the surveillance of anthrax. We were also interested to identify and map the high-risk areas of each country, and also we were assessing the knowledge and assessment, that means the knowledge of the people when it comes to anthrax. And there were another objective related to economic side of anthrax, leading by Joshua Onono from the University of Nairobi. He was also contributing to that part. So why we need... Okay. And here we have the rationale, the problem. Anthrax is the high public health economic significance of disease, and again, it's getting a disease. That means it's getting high intensity, and we don't know the drivers of this intensity of anthrax in the Horn region. There are a lot of cases that are anthrax, and so there's a need of integration between the animal and the human health sectors to participate in one health kind of surveillance in the region. As a result, so there is a limited data currently we have on the burden, the distribution pattern, the impact of this disease. So there is a much needed comprehensive understanding of the existing surveillance system and identification of the risk factors that are contributing again, and the areas that are the disease is prevalent. So this is the justification, and then we are targeting, as we have said, a large area We have Somalia, Ethiopia, Somaliland, Eritrea, and Kenya on board. And then in each country, we are selecting 2 high-risk areas. And these areas were selected based on frequency of anthrax outbreaks from the government side. We were visiting initially the government offices just to ask them the areas that anthrax reports were coming from, so we can target purposefully to that specific districts. So these are the specific districts we are targeting. In Ethiopia, we have Rigora and Hama waradas. In Kenya, we have Marugwa and Tigania sub-counties. In Somaliland, we are targeting Allai Bagai and Farawayna districts. In Eritrea, we have Debub and Gashparka regions. And then in Somalia, we have Galdogo and Beledweyne districts in central Somalia. And the study has both qualitative and quantitative components. We are doing key informants, and we are also doing questionnaire, and we are also doing mapping at the same time. So what are the activities we are doing from each objectives? The first objective of surveillance assessment, these are the activities we are doing. It's quite integrated and multi-method project. We are doing risk review of the available surveillance system from the government offices, particularly epidemiology department of both animal health and human health departments of the government. We are also evaluating the institutional structure and the interaction of each country. We are also doing key informant of these officials, from the officials. We are also doing mapping, and then and we are starting our mapping from the data of the risk review. That means the reports that are coming to the government offices within the last 10 years. We will search, we are searching that data, then compile it, and then assess it based on the report regularity, frequency, content, and source of these reports. And then we are also doing questionnaire, that means knowledge, attitude, and practices of farmers, postures, and abattoir workers that we call them as high-risk people of anthrax. And our sample size, we are just targeting 2 key informants from each district. So we have 12 districts. We have 3 layers of administration. So that means we are interviewing 2 key informants from the lower level, that means from the district level, and then from the regional level, and then to the national level. And then we are also distributing our questionnaire to the posters, abattoir workers, and the farmers. And we have collected around 1,536 samples in an equal manner from each country. And the sample size was well calculated based on estimated population size of each district from the government officials, number of households of the 2 selected areas in each country with a 95% confidence interval. So the data collection tools, some were recorded when it comes to the key informants, and we were using a digital data collection form, that means EpiCollect, using tablets to collect the questionnaire type of data. And ethical consideration, we had an approval from ILRI, that means International Livestock Research Institute, based in Kenya and Ethiopia. We have also cleared the project from each country again. We have approved it from the University of Liverpool lastly. And this has caused some delay initially of our project. Then later on, COVID-19 came, and we were not able to completely collect the data from each country. But luckily, currently I am talking to you, we have almost finished all the data except few from Eritrea, and we are in the writing stage. So the result of the project is not yet out from all the countries. Since we have harmonized the tools, we are using these tools for all the countries. So this has caused some delay to our project. But we have some expected benefits from this project. The findings from this project will help reveal the knowledge, attitude, and practice of people in the Horn of Africa, particularly those we call high-risk communities of Anthrax. The findings from this study will also enable the government and other stakeholders to undertake transparent and evidence-based decision-making when they are intervening outbreaks related to anthrax and even preventing the disease. And what are the expected risks? It's kind of loss of confidentiality. We essentially are collecting, since we are afraid to collect some personal data while we are doing key informants and the questionnaire, but we have clearly stated that in our ethical procedures and the information that we collect from the research project will be kept strictly confidential. This is an overview of that project. So thank you very much for inviting me, and that's it.
Thank you very much, Dr. Farah, for that insightful presentation. And it's a wake-up call to the intellectuals in the room that we need to venture One Health research. Allow me now to invite Dr. Ismas Gore, who is going to present factors associated with uptake and adherence to recommended public health measures against COVID-19 in urban and rural Kenya. COVID.
dadal halneba horkaca qusiyo habrasha kullida horumarkiyo ilinka nabad loo maray.
Amud University for inviting us to this wonderful One Health conference. And before I make my presentation, what Farah has just presented is one of the items I refer to in my presentation. The sandpit projects, training of mid-level researchers, and our focus really was multi-country, multidisciplinary, and you can see it worked. This is one of the successful ones, and we are very proud of it. So then I'll go straight to my presentation. And that is the title, Factors Associated with Uptake and Adherence to Recommended Public Health Measures Against COVID-19 in Rural and Urban Counties in Kenya. These were the institutes that were involved. All of us were from the University of Nairobi. I was the principal investigator, and those were the other co-investigators. They are all lecturers and professors from the then School of Public Health, University of Nairobi. And it was funded by HORN project. And this is the background, as you all know, that is the background. Towards the end of 2019, a cluster of patients were admitted to hospital with an initial diagnosis of pneumonia of unknown etiology, Wuhan, China, which was very well presented by Farah, and the disease was officially named COVID-19 and given the current reference name of severe acute respiratory syndrome coronavirus 2, SARS-CoV-2. This is well known to us. I will not go into it. The clinical features were initially well known. We know that the disease was more severe in the elderly, those with the comorbidities, and so on. So I will not go into that. But at that time, several public health measures that may prevent or slow down the transmission of the COVID-19 were introduced. And this included use of personal protective equipment, just such as the use of face masks properly. And I can see we are using the face masks very well today. and covering coughs, sneezes with tissues that are then safely diagnosed. We are familiar with all of this. Coughing into the elbow, sneezing into the elbow, and so on. Regular hand washing with soap or disinfection with hand sanitizers were suggested. In many countries, all the countries, this was suggested. And so our question, the study was conducted to determine factors to determine factors associated with uptake and adherence to recommended public health measures against COVID-19 in rural and urban countries. Just like here, these measures were recommended, but we know people were, some were using, some were not using, and the question was why were some using and why were some not using? Obvious questions. So that is what it seems obvious. So we decided to conduct a study to look at those factors. And these were the objectives. Factors that influence uptake of recommended. Uptake. You can uptake, wear the face mask, but do you adhere? The second was to determine factors that influence adherence. Using those recommended factors all the time. Uptake. And there are several, and we saw this, a variety. Some use them as a chin mask. I've seen some using them as a scarf, and so on. So this was the question then. So these were the study sites. One site in yellow was quite close to Nairobi, Nairobi, the capital city, and that was the urban site. And the rural site was in the western part of western part of Kenya. Those are the blue sites. A suburb of Nairobi metropolitan area, and then a rural site. So what was the methodology? Cross-sectional analytical study conducted in one electoral ward in rural and urban communities in Kenya. And a quantitative structured questionnaire was used to obtain the information. And this study was conducted strict adherence to COVID-19 regulations. It was conducted during the outbreak, and one of the requirements that it was to be done under strict COVID-19 regulation. So a questionnaire was posted on the ODK platform and administered by telephone interviews. So there was no face-to-face contact with the participants whatsoever. So it was administered by telephone interviews. So which was a really a new phenomenon for us in Kenya to conduct a study wholly using telephone interviews. So some of the steps, proposal development, and then there was ethical clearance, and there were several layers of ethical clearance. The first was the local IRB. We have our local Kenya IRB, we call it Kenyatta National Hospital, University of Nairobi Ethics and Research Committee. And then the second was NACOSTI, that is the National Council for Science and Technology. You have to obtain clearance to carry out any research in the country. And then the third was the University of Liverpool, which Farah has alluded to. Very, very strict adherence, and they insisted that you must adhere to COVID-19 regulation. So this took quite some time, but eventually went through. And then we had to get clearance from the medical departments of the two wards, rural and urban. In addition to that, we had to get clearance from the local authority where the study was being conducted. So those were the layers that we had to go through, which we eventually did. The next step was sensitization and awareness creation. Now the concept of telephone interviews was a new phenomenon, and especially in the urban areas. People are very suspicious to give their telephone contacts. And we had to get these telephone contacts without getting in touch with the people. So these were the steps. We went through the local administration, the chiefs and assistant chiefs. They were the first ones that were identified and sensitized as to the study goals and objectives in both the urban and the rural. So they were gatekeepers, so to speak. They in turn identified village elders in both areas who were also then sensitized by the chiefs and assistant chiefs. In turn, recruitment of the enumerators was done from the village elders. Then they also identified the enumerators, those who initially recruited the participants, and then they carried out the study. As you can see there, that's the training with some of the enumerators, some of the village elders at the top there. You can see us properly attired in masks and keeping social distance. The same is at the bottom here. This was a training of village elders plus enumerators in the urban area. Then recruitment of the households. The rural and the urban had their different challenges because of the setup of the urban population. Both were conducted by enumerators, but different approaches were used in each region. In the urban population, we had to use pamphlets. We printed brochures and pamphlets which we posted at strategic areas like water points, shops, telephone, electric poles, and so on. And we also used a public address system mounted on a vehicle, which crisscrossed the urban area several times, and we were able to recruit and get telephone contacts of the people. In the rural, it's a more homogeneous area, and using the local administration, the chiefs, they were able to identify village elders who are familiar with all the participants in their respective areas. So it was not as challenging as the urban, but still it was challenging to get telephone contacts of people. In the end, we did get the telephone contact. Sample size was calculated, 384 households in both the rural and in the urban area. So those were the methods that we used. Then, after that, we recruited enumerators. These were at least with diploma education upwards, and they all had smartphones. All of them had smartphones which were Android enabled and with the ODK platform. So then we went through the training of use of ODK application, both in urban and rural areas, in small groups. We trained them in small groups over five days, each of the areas. Virtual training and sensitization of researchers and project administrators on the use of ODK platform was done. And then followed by a supervised training of researchers in small groups of 9 to 10 persons, and eventually simulation exercises were conducted in using existing files. The next step was of data collection, creating servers for both urban and rural, then training, and then we carried out the survey, virtual telephone-based collection data using ODK platform, both for the rural and areas with passwords, with code-protected passwords for both areas. And then more than 400 households were interviewed in the rural county, and more than 390 households interviewed in the urban counting. What is awaiting analysis is the disaggregation of the data between the urban and the rural. But what we have is the overall overall information from both areas. So, the key findings. These were the key findings. The majority of respondents had first heard about COVID-19 from the media, radio, TV, newspapers. And this is not surprising. Up to date, there are daily updates on COVID-19 on our radio and TV, especially the radio. There are daily updates since the outbreak started. Updates with deaths, recoveries, the infection rates, and so on. So this was not surprising. So the majority first heard about it from that source. Hand washing with soap and water and wearing face masks were the leading measures known. Knowing is one thing. Those are the measures that they knew about. When you ask them which one do you know about, so those are the ones that they knew. Hand washing with soap and water and wearing face masks were the leading measures known. Again, not surprising, because this is what was emphasized on the daily briefings every day. Wear your mask properly and so on. But wearing face mask followed by hand washing with soap and running water were the leading measures currently being practiced. Again, wearing face mask and hand washing were, again, not surprising. So again, more or less what we expected. Now, again, the number of recoveries from COVID-19 was the leading news item or message expected to get an update on. But the second bullet there would surprise us a little. Fear of being infected was the leading reason for action. Fear of infected. We were a little bit surprised by that, because there was a lot of government pressure on people, and you'd expected that they would respond that fear of being arrested, because at times people were chased by the police and the administration that you must wear your mask and so on. So we were a bit surprised that for them it wasn't the fear of being arrested, but actually it was the fear of infection was the leading reason for their action. And then the most common barrier to action in both words, that it was not practical. Yes, wearing a face mask was not practical all the time, and hand washing was not practical because of availability of water. They said, okay, soap and water, sanitizer, these things are very expensive. So you are asking us to do these things, but it's not practical. Can't be done. And then discussion with community was the leading suggestion on what was to be done to make it easy to implement difficult activities. It appears that most of the information was top down. Do this, do that, do that. But there was no discussion. So they was telling us that, please discuss with us. Discuss with us some of the challenges that you are facing with us. So those were the key findings. And from those, then we turn those into recommendations, make the media, particularly radio, more interactive to provide accurate information for discussion, and especially during socialization. And then provide accurate information on rationale and techniques for hand washing with soap and running water and wearing face mask. What are the accurate measures? And then provide in a simple, appropriate and practical information on information dynamics of COVID-19 to allay fear of being infected and infecting others. One of our theories was that if people are aware of the transmission, this disease is transmitted, so then they would have a rationale that, okay, if I touch my face and eyes, this disease is transmitted in this particular way, then it would improve their adherence, their uptake and adherence to those measures. And then explore feasible and practical strategies of discussing with communities how to implement effective public health measures against COVID-19. So that again was response to discuss with us, discuss some of the challenges, discuss some of the let the suggestions come from us. Improve that and improve that so that there may be improved uptake. So those in a snapshot was our experience with uptake and adherence to COVID-19 measures. As I said, we have not yet disaggregated the data between urban and rural, but the key challenges, the key experiences we had was that it is possible to carry out a study adhering strictly to COVID-19 measures, and in particular the use of the ODK platform, a simple, relatively simple platform that we can use. But the challenge is obtaining the telephone interviews, telephone numbers from people. That was a real challenge, but those were some of the lessons I learned. So I would like to thank you very much for giving me this audience. Thank you very much.
Thank you very much, Dr. Ngore, for that wonderful presentation. I was just wishing that our students should have been here. And also, from his presentation, I'm challenged that we need to take research outside university campuses. Yeah? And also, grants are there. We need to attract them. Yeah? Grants are there. That's a good example of how we can attract grants and be able to gather information that's going to inform our communities. Otherwise, thank you very much. And during his presentation, I observed something, that there was loud consultation. Is it an indication that our batteries are low, are running low? Could be. And for that reason, I want to invite Dr. Mohamed Abdikadir to come and energize us a bit, connect us to power, so that our batteries can improve a bit. Welcome. Meanwhile, Professor Mirgisa should be ready. After this, you'll be the one on the floor.
Thank you very much. Bismillah ar-Rahman ar-Rahim. Alhamdulillah, salatu salam ala Rasulullah sallallahu alaihi wasallam. We do energizer with an active energizer with 4 of the colleagues. I need to call them from here. So everyone will take his own bottle. Yeah, his own bottle. 1, 2, 3. So you see, without collaboration, they didn't manage to get their water. So it is the simplest way they can do. They can come together and they coordinate between each other, then to realize to take their water, and even they lost the time, lost the limited resources of Africa. So this is our One Health approach. We need to collaborate with that. Thank you very much.
Thank you, Dr. for that role. The role play is reminding us of the 3 C's: communication, collaboration, and coordination. So because if they had communicated, they would have agreed who picks water, the bottle first. And then you could lead the other one to also get his share. Otherwise, thank you very much for that role play and energizer. Now allow me to invite Professor Lugisa to come and present on impact of climate change on animal and human health and implication on food insecurity in Ethiopia. Welcome, sir.
So thank you so much, and my appreciation to Amud University for the opportunity. Yeah, just a couple of disclaimers. Number one, before I just go into this particular presentation, I'll have a couple of slides to show the kind of Horn One Hills supported projects in Ethiopia, and particularly at Addis Ababa University. And number two, this particular presentation was selected on the basis of the objective of this conference itself. We have several projects, but this particular presentation fits very well into the concept of One Hills. I'm not saying the rest are not. And number three, this presentation was made back in August as a progress webinar that we are running amongst our principal investigators, and therefore this was modified to fit into this particular session. And the principal investigator is one of our colleague, Mulgeta Tamre, and I am one of the mentors, and the list of mentors are actually shown here. So the study is looking into the impact of climate change and its implication to animal-human health, targeting food insecurity in few places. So a bit of highlights on the research that we are undertaking, background objectives, methods, and preliminary findings. We don't have really a complete finding. So as it was presented yesterday, one of the 4 work packages of Horn One Hills is research, and at Addis Ababa University we have 15 sandpit fellows working on different One Hills projects in the country, and those sandpit fellows have come from different faculties, from the College of Health Sciences, from Veterinary Medicine, from the College of Development Studies of Addis Ababa University, and obviously from Akilul Lamma Institute of Pathobiology, which is particularly focusing on basic sciences. We have 3 One Hills fellows who are working on different areas. One from social work, another one from microbiology, and the third one from the School of Public Health. And we have one short sabbatical on antimicrobial resistance, who we sent to Kenya, Ilri, in order to do a short sabbatical from the School of Pharmacy at the College of Health Sciences of the university. And we have 3 small research grants for our PhD students. These are from the College of Development Studies, another one from Akulama Institute of Pathobiology, and the third one from College of Veterinary Medicine of Addis Ababa University. We have one important research that we actually designed in order to bring 4 of our co-PIs from Addis Ababa University. This is a street dog project where we brought a microbiologist, a public health professional, a social scientist, and a veterinarian together to actually work on street dog relationship and zoonotic diseases. After we have done the early mapping of this, unfortunately, the project couldn't continue because of the context that we have in the city of Addis Ababa. So Horn project, these are the places where we are actually running the project. Addis Ababa on COVID and street life of human and dogs. And we have Butajira, our Butajira surveillance sites where we have COVID, fasciolasis, AMR, one health wash projects, toxoplasmosis, maternal health and zoonosis, which we are actually undertaking in collaboration with Jimma University, as well as Kilita Aulalo Mekele University DSA sites. And of course, pastoralist areas, Afar, Somalia, Oromia, SNNP, we have Rift Valley fever. Of course, this has been, addressed a few times, and human-animal environment nexus, and the food insecurity, climate change that I'm actually going to present. So basically, this is just to share with you, the kind of project that we are running with funding from Horn One Hills. With respect to this particular presentation that I'm making on the impact of climate change and the implication on animal, human health and food insecurity, as we all understand, climate change is a global phenomenon now. I mean, it's not something that we talk in abstract. It's something that we see in reality as it evolves, and that has to do with temperature, wind, precipitation, and so on and so forth. We are seeing that global warming, which is driven by human-induced emissions of greenhouse gases, and of course, it has a large-scale shifts in weather patterns across the globe. And of course, Ethiopia is not unique for that matter, and the Horn of Africa is not. So the extreme climatic and weather conditions are exhibited by droughts that we are seeing, flood and excessive heat. That is basically increasingly common phenomenon in Ethiopia. We are seeing these situations in the country as we see to date. And with pervasive geographical coverage, now climate change is actually contributing to health, ecological and humanitarian crisis in the country. Sorry. Yeah. So again, just to specify a little bit, when we look into the effects of climate change on the environment, we are seeing, of course, temperature, increasing temperature, change in precipitation, change in rainfall and erosions, decline in organic matters, salinization, soil biodiversity losses, landslides, desertification, flooding, increased danger of wildfires. So the most important point here is what is the implication of those on food security in the country. When it comes to, again, the health aspects, we are seeing heat stress, immune suppression causing infections and deaths, the quantity and quality of feed stuff for animals, the shortage of drinking water, survival and distribution of pathogens, vectors of animal diseases. These are issues, some of the highlights that has to do with animal health. When it comes to human beings, of course, heat stroke, effects on the body's nervous and respiratory systems, stress to food producing systems, the global spread of infections, and disruptions to economic and social activities. Now, looking into World Food Program report, we are seeing that countries in Africa, and more particularly in the Horn of Africa, are now becoming chronic hunger featured, where, as you can see, Chad is the most devastating part of Africa, but Ethiopia, Somalia, and all those coastal areas of Africa are actually food insecure. We are seeing that 15 to 25% of the population are actually affected by drought. And as we see now, if this continues by 2030, which is 8 years later, probably 840 million population of Africa are going to really suffer food insecurity in this part of the world. So the reality is that we see now what I have been talking about is actually exhibited slide, as you see on the far right, and of course wildfire, death of animals, and the extreme drought that you are actually seeing in different parts of the country. So the objectives, this is a mixed method, sequential design, where we are actually, where we have undertaken specific, trying to address specific questions. Number one, describe pastoralist communities' awareness of climate change. Are pastoral communities aware? I mean, this morning, since yesterday, we have been talking about One Health. But the most important point is how much of One Health do we really understand ourselves? And can we actually transpose this to the pastoral communities themselves? Do they know about it? What do they know about it? Explore the implication of that. Animal human health. Do also they recognize the implication of this climate change to human and animal health, and they explore implications of affected animals and humans on food security of the local community, and if there are coping strategies. And there is a quantitative element of it where we wanted to assess the prevalence of food insecurity, identify factors associated to food security, and identify the magnitude of the impacts. So we have carried out these studies in 3 pastoral settings: Afar, Oromia, Borana area, Somali region of Ethiopia. So as you can see, Liban from Somali, Borana from Oromia, and Afar in the northern part of the country was actually targeted. We have, for qualitative study, we have actually carried out focus group discussions and key informant interviews. Focus group discussions with women, mothers, and members of the communities that were selected for the study. And we have also carried out key informant interviews with key influential leaders, opinion leaders in the community. For the quantitative, we've calculated mothers with under 5 children. That has to be distributed into the 3 areas proportion to the population. Well, the qualitative part, we have collected all the qualitative data, and we have used thematic analysis with that software, and the quantitative element is meant to actually describe using logistic regressions, for ethical elements, we have got ethical clearance both from University of Liverpool and from the College of Health Sciences at Addis Ababa University, and of course permissions were secured from the respective communities we have actually plans in order to share the results from this study. So the study is yet going on, and the qualitative part is finalized. The data collection is completed. The analysis is done. We are actually writing up the report. So the results that I'm sharing with you is only from the qualitative part. So it's not complete yet, but the indicative findings are as follows. Number one, shared community awareness about climate change as exhibited by observable change. Now, what is it that the community observe and understand about climate change? From the last 15 years, the number of camels and goats has steadily decreased. So the number of the population of those livestock, those camels and goats have reduced, exhibiting changing climate. So that's the suspicion. Diminishing water for human being and cattle, dryness of the ponds and local water sources. So water has become a major area of concern as it has been exhibited. The deaths of domestic and wild animals, this is quite common kind of experience that the local communities have actually provided us as piece of information. Compromised availability of food for humans and animals, and animal products as food has greatly dropped. So their understanding, their awareness of climate change has been explained in terms of those important elements. The shortage of an increased dryness with diminishing water and sources have been actually attributed to the changes in the local environmental conditions. This is one of the places in Afar, Elidar, that clearly shows complete dryness that actually exhibit the diminishing water sources and subsequent animal and human feeds. Household income is the reflection of what happens to animals that in turn is affected by what the environment offers. So if the environment does not offer much, and then actually human health is being compromised, and the income of the community is compromised. So this is a very good quote. The income of household and the way of life is directly related to our animals. With growing lack of water and animal feed, their milk, meat, and price has actually dropped. This directly affects the availability of food for the family. So this is actually the indication of it. Unknown diseases are now increasingly posing a threat. Sudden deaths of camel within a short period of time with such symptoms as weakness and paralysis for both the upper and lower limbs, shortness of breath and cough, and acute diarrhea and abdominal detention is unusual, that poses serious challenge to us. So this is also an example that shows the change that we see. There are more threats to animals than ever challenging human livelihood. So we are seeing animal malnutrition, wasting and stunting, ingestion of plastics. Now plastics are everywhere. Animals are eating plastics instead of grasses because grasses are not available. Shortness of breath of goats, reduced production of milk and products, and reduced size of the herd. These are critical indication of threats to animals. More challenges are also exhibited during COVID-19. So they have indicated that there are movement restrictions, there are lack of usual aids that are coming for animals and humans. This is also an indication of change in connection to COVID. And desert locust crisis, livelihood, food security, and nutritional status of both animals and humans have been compromised. And there is continued conflict among pastoralists, between pastoralists and highlanders over scarce resources. These were indicative findings from the field. Who are more affected? It has been indicated that children, with changing climate, with failing water, animal feed, there is compromised nutrition for children. And the same is true for pregnant women, with vivid wasting of pregnant women due to lack of adequate food has been indicated. And although children and women are affected with food insecurity, the elderly as well are again affected with that. What are the coping strategies? Now, these are coping strategies that were identified by the community itself. Charcoal production. In all the study settings, it has been argued that charcoal production has become the major source of income that is actually compensating the kind of resources that would have otherwise been coming from animals. Collecting and selling firewoods, getting support from government NGOs, now they are being supported. These are food insecure areas, and government is providing food rations. Slowly aligning pastoral life with other economically gainful activities have been actually identified. Seeking refuge for animals in highland areas and or persistent seasonal migration in order to keep their animals has been the coping mechanisms that were adopted. So what do we say? The implications of climate change are obviously complex and calls for multi-sectoral actions. This morning we were talking about what can we do. There are plan of action, declaration, and so on and so forth. Those of us who have come from the universities, of all things, we have to actually align One Health principles approaches to our teaching and research activities. Very simple, right? But it's not about health. It's about agriculture. It's about water resources. It's about other sectors too. So that commitment of multi-sectoral collaboration appears to be very, very important from the finding itself. Interventions should be integrated where animal, human, and climate could as well be considered. It's not just animal. It is about human as well. It's about climate too. When we talk about climate this morning, somebody was talking about marine, about fishes. We are taking our students for practical community attachment of 6 weeks, and in a community where there is a lake where we produce fish in Zawai. Now that fish has actually been contaminated because of the culture, flowers that are being produced. So we have to really look into those elements. Educating the local community, the coping strategies and early warning is very important. Immediate interventions to improve water schemes and animal feed is very important in order to improve food security. And more efforts need to be done to understand the role of pastoralist communities. Now the role of pastoralist community in the coping strategy is very important. It's not us actually planning for them, but they actually playing their own role in that process. The way forward, we are planning to finalize the analysis of this paper, this document, and produce manuscript out of it, the quantitative data collection, which was supposed to, which was supposed to be completed by now. Because of the insecurity, the security situation in Afar, we couldn't do it, and therefore we have actually asked for modification to actually do the research in southern part of the country. So we have asked IRB both in at Addis Ababa University as well as in Liverpool to actually allow us to do that, and we are actually planning to collect the data in the next few weeks in order to complete this process. So thank you so much for your attention.
Give him another clap, please. Give him another clap. Thank you very much, Prof. That was a wonderful presentation. And you'll agree with me that Nairobi University and Addis Ababa University has shown us the way, because universities are supposed to transform the lives of the population. And the research they have done will help to transform the life of the population, because we are supposed to get out of classroom and go out and carry out research and fill in the knowledge gap and help transform the life of our communities. So thank you very much, Addis Ababa University and Nairobi University. We have come to an end of today's presentations, but we had skipped two. That is, we were supposed to have had open discussion to look at a few questions, 3 questions. One is there a need for Horn of Africa One Health Network? What are the existing or foreseen challenges, threats to regional One Health Network? Is there an opportunity or opportunities for networking? So I want to give ourselves a takeaway. Let's go and think about these 3 questions as institutions, organizations that are represented here. Tomorrow we'll see if we can create time for feedback from respective organizations and universities. Then the other item that was skipped was a presentation by Yusuf on knowledge and perception of COVID-19 among healthcare workers in Somaliland. So this one we'll also see if we can get time tomorrow and have a presentation on that. Otherwise, that marks the end of today's session, but I just want to give a brief summary of the day. We had presentations from countries which was much more of experience on health, One Health, and from the presentation, you'll agree with me that we are at different milestones. Others are still at conception stage. Others are at toddler stage, young adult stage. So that shows that we need to come together and support one another so that those who have not seen their 5th birthday can be able to experience that. The other thing that emerged from today's presentations was that there is need for us to identify mother ministry. 1, for coordination purposes. 2, for political goodwill. We cannot exist without a mother. We need to identify mother ministry, though this one will depend on the individual countries. Because some countries it might be Minister of Health, Minister of Livestock, Minister of Agriculture, but let's take the talk home. Let's continue discussing that. Then we should be able to identify way forward. Then there's also an issue that emerged from Kenya's presentation, that where is wildlife in One Health? Because in Kenya we know most pastoralists venture into game wardens, and that has resulted in zoonotic diseases because of the interaction between human, livestock, and wildlife. So to some countries it might not be relevant because maybe there are no wildlife, but we've seen that's another issue that's coming up, that where is wildlife in this? The other issue that came up was our issue of sustainability. The issue of sustainability, and that gave birth to a big question, where is community in One Health? The other issue that also emerged was the issue of concept of One Health. How far can we take it? Concept of One Health and the aim of One Health. Currently is looking at research and capacity building, but you have seen some innovative ideas are emerging that we need to involve the community. Even take it down to the extension workers so that they can own the process and then continue with it. Then that will ensure sustainability. Another issue that came up was, for me at least, there was a solution is emerging concerning the non-domesticated dogs in BORAMA. Dr. Gidi, I think, has a solution to that we need to come up with a program to vaccinate them, to mitigate possible outbreak of rabies. Because to me, that's a time bomb. That BORAMA is sitting on a time bomb. One day, if there will be an outbreak of rabies, maybe we'll send many people to the grave. So we need to mitigate that before it happens. There's also a point that was raised that public health threat is a threat to security. So we need to sensitize our governments so that we're able to address One Health, or to embrace and mainstream One Health, because public health threat is a security threat. Livestock is also a wealth in the Horn of Africa. You have seen camels dying. How much does one camel cost? It's about $700 to $1,000. Imagine somebody losing 3 or 4 camels. How much have they lost? So we are sending people to poverty. And you know poverty is a determinant of health. Then lastly, there was a big question. Yes, we are sitting here. Yesterday we sat here. Today, tomorrow. What is the output of this conference? Do we need a BORAMA One Health declaration? So think about it. Otherwise, from our desk, I will say thank you, and I'll invite Yusuf. If you have any housekeeping issue, you can share with us. Yeah, Yusuf is just reminding me that maybe we have starved you from asking questions for clarification based on the presentation we have had this afternoon. I was skipping that because of time, but I would ask you for your wisdom. Do we continue and allow a few questions for clarification, or our battery levels have gone down? We can come back tomorrow. What's the wisdom? We continue? Tomorrow. 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 Thank you very much. Otherwise, from us, we'll say thank you very much, and thank you for your cooperation. See you again tomorrow. Thank you very much. Why don't you clap for me? Thank you very much. Thank you very much. Thank you very much.
Lift your house.